6 o'clock. I think we should probably get started. All right. Thought I'd welcome everybody to our first Spine and Wine of the year. I don't know if we're supposed to call it Spine and Wine, but I think that's what everybody calls it. So all of our physicians at CSO want to welcome everybody to the lecture. Tonight we're lecturing on diabetic neuropathy, causes, symptoms, and treatment options. And it's going to be Dr. Eric Kuhlman and Dr. Paul Leo talking on this. This is our first CME event of the year, and it's a bi-monthly series where we feature spine, orthopedic, pain management, and other related topics. I also want to thank Health Images for co-sponsoring our lecture series for the second year in a row. Tonight, Dr. Kuhlman will present the causes and symptoms of diabetic neuropathy, and together he and Dr. Leo will discuss medical and surgical options for treatment. Dr. Leo then will elaborate on the latest advances and the use of spinal cord stimulation, which recently received FDA approval for painful diabetic neuropathy, which is pretty exciting. A little bit about each physician. First, Dr. Kuhlman joined our practice in April 2017 after finishing a advanced surgical reconstruction fellowship at the Professional Education and Research Institute of Roanoke, Virginia, which is a great name. During that time, he performed 2,000 complex foot and ankle procedures on the coal mining community in that area, caring for many of the patients who had really never seen a patient before. Dr. Kuhlman took that and continues to recognize that each patient has a unique set of foot and ankle conditions. He takes immense pleasure in listening to each individual and formulating the best treatment suited for their needs. If you ever get a chance, check out his online reviews, and you'll get a sense of how much he cares about his patients and how enthusiastic his patients really are for him. Another thing is Dr. Kuhlman is a great guy. I've had the pleasure of being his partner now for a year and a half. He grew up in Toledo, Ohio. Spends most of his free time with his wife, who's also a podiatrist. They have 2 dogs. Dr. Kuhlman is an avid Atari player, and his best game is Pong because it doesn't require a lot of aptitude, I guess. I would have thought he did something harder. In his spare time, he enjoys hiking 1,400-foot peaks, skiing, snowboarding, and playing golf. And he's just a wonderful guy and technically an absolutely gifted surgeon. I had the pleasure of training and working with podiatrists in the Army for 5 years. And he is certainly the most gifted foot and ankle surgeon I've worked with. And there's Dr. Leo. So Dr. Leo is, this is, his second talk as well as Dr. Kuhlman's. So Dr. Leo is double board certified in anesthesiology and pain management. He applies his multidisciplinary approach to pain management. So he's able to combine therapies, medication, and interventional procedures. Dr. Leo's performed thousands of procedures, including spinal cord stimulator implantation, intrathecal pumps, radiofrequency and cryoablations, cervical and lumbar spinal injections. Those are like epidurals and facet injections. I personally send him all of my very complex injections because he just has a natural apt to be able to do them well, and I can trust the result when he does them. He does other things besides spine injections. He also does a lot of joint injections, trigger points, dry needling, and like PRP and bone marrow aspirate injections as well. His goal is always to find the best solution for each patient. It's never a cookie cutter algorithmic approach. He really thinks and tries to make every patient's pain individually better. So Dr. Leo earned his medical degree at SUNY Downstate Medical Center in New York City. Then he completed anesthesia residency at New York City Mount Sinai School of Medicine. And there he also completed a pain management fellowship. He's practiced in multiple settings from level 1 trauma centers all the way to community-based clinics. His specialties, as I said, are pain management, regenerative medicine, that's the PRP and stem cell injections, medically assisted treatments, and anesthesia. In addition to treating patients, he also enjoys training medical students. We always have medical students here at CSO and pain management nurse practitioners that rotate our practice through our practice and work with them frequently. Originally from Brooklyn, it takes a few minutes if you know Dr. Leo to know that he loves skiing, being with his family, baseball, kung fu, and astronomy. And he's been in Colorado since 1994. So, and the last person to introduce, and probably no offense to myself or Kuhlman or Dr. Leo, is Dr. Downs, because he's the guy who controls the wine portion of the thing, and that's why I certainly sign on each time, because I know these guys. These guys tell me all this information, but I get to learn new stuff from Dr. Downs. So prior to the lecture, Dr. Downs is going to give a talk. He's our wine somm who is leading the wine tasting again tonight. He's a retired OB-GYN physician who specialized in infertility. He's been a somm for more than 5 years, and now he's an event planner at Wyatt's White Goods in Longmont. He became interested in wine during his years as a physician. So with that, I will leave it to Dr. Downs to lead the wine tasting.
Good evening. Welcome. Tonight, I thought I'd do a wine from one of my favorite places that a lot of people don't think about when they think about drinking wine. I got a wine from Portugal. Normally, when people think of Portuguese reds, particularly, they think of port. Port's is a sweet fortified wine, about 20% alcohol, that's great on nice winter evenings with maybe some nuts and some fruit. But Portugal is getting much more well-known now for its still red wines as well. So I brought an example. It's one of my favorites. It's called Silk and Spice, and it's really aptly named. This is a really cool wine. It has great press. It's got 90 points or better 5 years in a row from the Wine Enthusiast, which is one of the better wine journals in our industry. So a lot of people think it's a good wine, and I'm included. This is a really good, as most Portuguese wines are, it's a blend. And this is actually a blend of 4 grapes. One grape is called Touriga Nacional, and you may have never heard of it, but it's really considered the noble grape of Portugal, much like Cabernet Sauvignon would be the noble grape of California. So it's extremely well known there. It's a very important grape to use in port, but it's also used in most of the still wines as well. There's another grape called Baga, which nobody's ever heard of, but it adds a little bit of acidity to the blend. There's Syrah, which is a very well-known grape, and it adds some spice and some smoke to it. And finally, there's Alicante Bouschet. And Alicante Bouschet is a really cool grape, and then one of the reasons I brought this wine here, this is one of the few Teintura wines. And a Teintura grape is a grape that actually has red flesh. Of all the red wines you drink, 99.9% of them are red. They have red skins and they have white flesh. But Alicante Bouschet is red through and through. So the resulting wines are deep in color, deep in flavor, and it's really a cool grape. It doesn't work well on its own because it doesn't have very good acidity, and the wines tend not to work well, but it's amazing in the blend. So this wine, when you taste it, when you open it up, the first thing you notice a really intense aromas of red and black fruit, and maybe some blackberry, some ripe plum, really a cool wine. The palate, again, you get those fruit flavors, but you get this incredible spice, black pepper, pink peppercorns, kind of hints of mocha, vanilla, just a lot of flavor with this wine. It's full-bodied, but has a really good balance of fruit and tannin, just enough tannin to make it interesting. And the finish is one of the longest of any wines I've ever had. It lasts forever. So enjoy this wine. It's great with food. It's awesome just to have a glass. It's a very easily found wine in just about any local liquor store. And it's not an expensive wine as well. It's about $12 or $13 a bottle. So enjoy the rest of the CME tonight. It's going to be really good. Cheers.
All right, thanks, Dr. Downs. I'm going to stop sharing real quick just to get our video started here. Here we go, so you can see our beautiful faces. Maybe. Sorry, give me 1 second. All right, can everybody hear me now at this point in time?
You're good.
Good, okay, perfect. So I appreciate those lovely introductions, Dr. Rumley, as well as the wonderful wine evaluation. It's a really phenomenal wine. Today, what I want to talk about, and Dr. Leo would like to talk about, is just a little bit about diabetic peripheral neuropathy. I'm going to go through kind of the causes and symptoms, and I'm really going to leave the treatment portion up to Dr. Leo. And I think I kind of want to take you guys mostly to the treatment, just because some of the things that Dr. Leo is doing is just essentially pretty groundbreaking on the things that he's able to do for these neuropathic patients. I've had a few, and he is going to explain in more detail than myself, but I've had a few of his patients come back to me with just absolutely phenomenal results, things that I have not seen in my career. And I know it's still a little short-lived. I've only been doing this for about 10 years, but still the things I've seen that he's been able to do has been pretty phenomenal. So just going through quickly on my end, essentially talking about diabetic neuropathy, the causes, essentially my screening tools, because I think from my practice in particular, where I see some confusion is kind of standardizing some of the treatment and for Dr. Leo to kind of go forward with, being able to do a really good screening evaluation, being able to say, hey, is this small fiber? Hey, is this large fiber? Is it a combination? Really, what are we attacking is really helpful to give to them. And I mean, he is more than capable of coming up with those screening tools himself. But when I try to lead patients to him, I try to give him the best screening evaluation I can. And then just differentiating some of the symptoms between some of the different diabetic neuropathies. I think we see, a lot of people just focus in on the stocking and glove distribution, but there's, truncal neuropathy, entrapments that do definitely come with our diabetic neuropathic patients. So causes of this diabetic neuropathy, and it gets pretty in depth if we want to, but I try to simplify this the best I can. And what we see typically, about 40 to 50% of people with diabetes will have some form of detectable neuropathy within 10 years, whether that's poly or mononeuropathy. It's really person dependent, genetic dependent on kind of how they end up with or what they end up with and kind of that glycemic control. What I see typically, this increased risk, foot amputations and ulcerations are massive for me. And so, I was the director at the Wound Care Center at North Suburban for about 2 years, and we would see these massive ulcerations on these patients that would come in essentially whole foot, and they were completely neuropathic, never even knew it was there. And this would really increase the morbidity and mortality rate for these patients, because if they left those ulcerations uncared for, what we would see then is the need to go in and really clean this tissue out, and we would end up having to amputate these feet, legs, and even doing a complete leg amputation, which would definitely increases that mortality rate for these patients. The 5-year survival rate after a major leg amputation is not really good. We would also see these patients with pretty significant neuropathic pain, which then we would again have to refer to our PMR colleagues to try to really manage these patients. And once they got to these increased risks and increased essentially high levels of neuropathic pain, we were getting really limited on what we could do for them. And that's where Dr. Leo came in and was able to do some pretty phenomenal things. When I talk about neuropathy with my patients, I kind of show them this picture. And what I'm trying to demonstrate to them is kind of the progression that they get as time goes on. And what we're doing here is we're looking from left to right, and we're seeing the normal healthy tissue. We're seeing the capillaries, the venules kind of going all the way to the basement membrane. And we're seeing those neurovascular structures kind of going into the skin tissue envelope. And then we have that diabetic incident, whether it be a hyperglycemic event, whether it be a microvascular event, a microvascular, macrovascular, kind of any of those events that can lead to some tissue damage or essentially having those neurovascular structures kind of reduce. We start to see the structures kind of reducing past the basement membrane, really retracting into the deeper tissue layers. And what we see then is when we have that decreased sensation, that's where we get the injury of tissue. And that's kind of that fourth column over there where we get that initial injury, whether that be keratosis, a corn, a callus, a real quick cut into the skin. But that first injury can lead to even worsening progression till we get to that final column where we're actually seeing necrosis, and patients unfortunately end up with having amputations or really significant wound care. And again, those comorbidities and comortalities that come with that. When we talk about neuropathy, we really talk about what increases those risk factors. And I think the primary care world can speak volumes to this, of having the increased blood glucose levels, high BMI, smoking, hypertension, and the elevated triglycerides. And I love this picture on the right just because it just kind of always makes me giggle a little bit, because we have the metabolically healthy individual and then the diabetic individual, which are definitely different. But what we're seeing is those axons just starving for attention, starving for food, starving for everything that they really need. And they're just not getting it because of kind of the pathophysiology behind diabetes. And when we talk about neuropathy, we always want to dig into our microvascular and macrovascular complications. And with diabetes, our microvascular structures, we're always worried about that sensory and motor neuropathy, autonomic neuropathy, our retinopathy, kind of those more basic things. But then when we start talking about our macrovascular issues, our big bucket items, our coronary artery disease, our peripheral arterial disease, our gastrointestinal, kind of the gastroparesis type picture, we're really talking, those are when it gets pretty significant, because now we have these patients that have, arterial structures that are not feeding the blood vessels really well to the nerves, the skin tissue, and they have complications that come with healing factors, especially when it's, again, for me, having those amputations, ulcerations that deal with these peripheral arterial disease complications. Now, I was a physiology major, and so I'm a physiology nut. So I like talking about the pathophys of kind of neuropathy and a hyperglycemic state. And this slide is very busy. And I definitely have another slide at the next one to really kind of simplify this down, because this is something that I try to always educate my patients on, because I can't tell you the number of patients that come into me when I ask them, well, talk to me about your neuropathy. Is it worsening? Is it getting better? How did it develop? They're like, well, my doctor said it was because I had diabetes. And so I really then try to go in and educate them. And I don't go into this much detail on this slide, but I definitely try to educate them on what is happening to their body. And I try to break it down into more of a vascular component and then a kind of metabolic type component to each of this. And so from a vascular side, what we're seeing is that the nerve is actually getting decreased blood flow. And whether that's because of increased protein kinase C, where we're getting those kind of atherosclerotic changes to the blood vessel, and that's decreasing the blood flow to that nerve tissue in particular, or it's the nerve tissue is becoming more resistant because those nerve structures are getting glycosylated, or because they're having those kind of advanced glycosylation end products, or those AGEs. We're seeing that on the nerve tissue causing damage. Now, the other, from a metabolic standpoint, we're seeing the polyol pathway, and that is one of the more key ones that we're talking about. From a general perspective, trying to simplify it as best I can, what we're seeing is that most of the tissue in our body has a glucose that needs for energy. Typically, in a lot of different cells, we have insulin-mediated glucose kind of change between that cell. But in the nerve structures, in our retinal structures, in our kidney structures, glucose moves across that cell membrane without the need for insulin. And so when we're in a hyperglycemic state, what happens is the glucose builds up in that cell, and then the polyol pathway kind of kicks in and starts converting this to sorbitol and fructose. And unfortunately, those things can't get through to the cell. And so when that happens, it kind of eats up our NADPH and creates kind of this oxidative stress, which creates osmotic changes to the nerve and then kind of creates the damage as well. Now, when I talk about that to patients, obviously I'm not going into that detail. I show them this, and I show them that, hey, when you are at an increased kind of hyperglycemic state, when your blood sugar levels are high, your body is actually causing damage to your cells on a microscopic level. And what I try to explain to them is, again, a vascular component and a metabolic component. And I say, from a vascular component, we have blood flow. And what our blood does is it kind of feeds our body. And so if we don't have a good enough blood flow, the body kind of starves for it, which then creates damage and then can create that neuropathic feeling and those neuropathic changes. If we go from a metabolic standpoint, I try to explain them that from a cellular level, those high glucose levels are building up in the cell, and then they get trapped in there. And then that again creates kind of those end stage reactive changes, which then leads to the nerve cell being damaged and becomes dysfunctional. And that creates kind of the neuropathic changes as well. This slide for me here is kind of one of my take homes. I love to give people take home messages, take home slides. And for me, this is a huge one, just because this is something that if you're having a hard time explaining to your patient, if they're asking you, hey, why is my neuropathy developing? What's happening? Instead of just saying, hey, it's because your blood sugar is too high, at least you can explain to them in a little bit more detail, really what's happening to their body and what's going on in there. And I really think showing them a picture and explaining this to them in a little bit more detail is always a little bit more helpful for helping patients understanding. And I think, empowering that patient to really take their diabetes into their own hands at that point in time. So screening is so broad for a lot of different people, and you look at different texts amongst podiatry, orthopedics, and primary care physicians, and we all have similar things. But I think what happens is there's no real standardized approach, and I included in essentially the pictures that I was given from my primary care physicians, and it differs completely from kind of the pictures that we are taught and how we try to standardize it in a foot and ankle world. And so when we talk about screening for diabetes, one of the bigger ones, we're talking about, those large fiber neuropathy, we're testing kind of that Sims-Weinstein monofilament. And I think this is something we all do. One of the big key components to this is trying to standardize this. And this text here, it kind of says do it 4 times per foot. And I, as a podiatrist, always do it 10, and I do it in a very standardized approach. And so what I'll do is I initially try to show them this light sensation touch. And for me, they always say, do it on the sternum or on the scalp, or show them on their hands if they can still feel it. It's always weird to go from this, down at the bottom of the foot all the way back up to their scalp. So I try to show them either on their lower leg, their knee, or if they can still feel on their hand or arm, just so they can differentiate that feeling and with their eyes open. Then I'll actually have them close their eyes, and I'll do 10 different points. And my 10 different points are here. And so I do one on the top of the foot, in between the great toe and the second toe. And then the rest of them are majority on the bottom of the foot. And so even on my EMR system, I find it really funny, because what happens is it says Sims-Weinstein, and then it has a yes or no. It doesn't say 10 out of 10. It doesn't say, 4 out of 10. So what I do is I actually write this into my kind of physical examination findings, is I'll write in, 9 out of 10, whatever was present. And I always do it the same way. Great toes 1 on the top, and then I go from the bottom kind of clockwise over. I go great toe 2, third toe 3, and just kind of keep going, just so I can standardize it for myself. Now, if they're completely negative all the way back to the heel, what I'll do is I'll start increasing up the lower leg until they can feel it. And then I do 0 out of 10, but then I do present at, so-and-so, whether it's mid tibia, proximal tibia, just essentially where they feel this light touch sensation at, is really where I try to kind of standardize it to make it a little bit more easy for my colleagues to understand. The next one, and I find this funny because vibratory sensation, another essentially large fiber neuropathy finding, they show it here on the second toe. And I was never, even on this on and off method, taught to do it on the second toe. We always do it on the first metatarsal phalangeal joint. So that great toe knuckle joint, we always do it there. And I think this one is the hardest one for most people to get, because there is some nuance to it. And so when I do this test, I try to, you have an audio clue when you hit the thing on your hand, they're going to hear that vibration. So I try to give them a beat or two before I actually put it on their great toe knuckle joint, just because I don't want them to cue into that sound cue and say, hey, I feel it. And then they hear the sound cue stop and say, I don't feel it, because then that can trick us, correct? So for this, I'll hit it. I'll wait a few seconds before I put it on the great toe, first MTPJ, and then place it on there. Essentially, I'll try to stop it the best I can with it being as minimal sounding as I can, which I know sounds a little bit more challenging than it is, but I'll put my finger kind of between the 2 prongs there, and then essentially try to let that decrease over time. If they don't feel it at the first MTPJ, I go up to the medial malleolus. If they don't feel it there, then I go up to the tibial tuberosity. Now, one study that I came across from our primary care physicians was that when they do that first initial screening for our patients with diabetes with neuropathy, about 80% of the time they actually miss the physical exam findings on the lower extremity, meaning the foot and ankle. So these 2 tests are super quick. It takes me probably, a minute per test to actually do. And you can always add or test or even subtract tests or just send them over to me to really get a good kind of examination on the foot and ankle. But I'll also do kind of hot cold. I'll do proprioception, which are a little bit more time consuming to explain to a patient and actually performing. But these are two tests, I think, from a screening standpoint that is something that most of us have available for us to perform, as well as having just the access and ability to do it. I think these are two of the very easy tests to do. The other one that I would recommend we could do would be the pinprick sensation. And most of us have those cot tip applicators. What I'll do is I'll just kind of snap one in half, and the sharper the two ends, I'll have them shut their eyes and tell me if they can feel a sharp or dull sensation. And that usually does a pretty good for that kind of pinprick sensation test. Now, with the further screening tools, what I utilize in my office here is if the patient comes to me for an initial diabetic foot screening, typically I'll send them for an EMG NCV just to give me that baseline information. And what I'm really looking for is to give just a more clear picture of what is going on. Is it demyelinating? Is it axonal damage? Is there motor? Is there sensory? Is it kind of more broad? Just to give me a sense of really kind of how significant and severe this is. I also think this helps my colleagues like Dr. Leo once they kind of have a better picture of what's going on from a more global perspective from the neurovascular tree, just to be able to give them more treatment options available. And the last one is an actual skin biopsy. And this is pretty rare that I'll do this, I'll be honest with you, but this is more for my initial small fiber neuropathy patients. So say you get a patient, they're neuropathic, or they're not neuropathic yet, but they're diabetic, and they're coming in and they complain of burning fit sensation to the skin and kind of this hyperalgesia, the sheets touch it. And you're like, well, what's really going on here? They get in at EMG NCV, it's normal. And so you're like, well, I'm going to send this to the foot guy, try to figure it out. So if I get this patient who everything from a neuro standpoint is coming back normal, I start to think it's more of a small fiber neuropathy, and I'll actually biopsy the skin. How I'll do this is I'll take 3 different sites. So I'll take one just proximal to the ankle joint of the skin, kind of the proximal calf, and then I'll take one from the thigh. And it's just a real small 3 millimeter punch biopsy. So they don't require stitches. They don't require any of that really aggressive kind of care afterwards. And it's just usually let them heal even without a stitch if they're bleeding a ton or there's a bigger section that comes out with the 3 millimeter punch. Sometimes I will throw a stitch in there just to make it a little bit more easy for the patient. But this is really minimal wound care. I'll just put a bandage on there and kind of let them go about their business. What I'm looking for here is we're actually taking a look under the microscope to see what these small fibers are doing. And we're kind of comparing and contrasting. Did they have a lot of small nerve fibers within the section that we took? If they're decreased compared to normal, then we're really seeing and looking for that small fiber neuropathy at that point in time. So moving on beyond the screening tools, the symptoms of diabetic neuropathy, and I try to break it down into a few different here. So I try to break it down into large fiber, small fiber, and then kind of the mononeuropathies. I leave alone the entrapment. The entrapment neuropathies are more from trauma, and those are kind of self-explanatory. You get someone who gets hit right around the peroneal nerve in the lower leg. They start to have some symptomatology with those entrapments, and we'll just do symptom relief. And those will usually tend to resolve over time in treatment, and we're doing more of the symptom relief at that point in time. And then the proximal motor neuropathies, I just don't really touch on because I'm looking more at the small fiber, kind of the stocking and glove distribution, which we mostly see, and then the mononeuropathies, which are something we see more in our primary care world at all times. So when we talk about the small fiber neuropathies, we look at both acute sensory and kind of chronic sensory issues. And I see this acute sensory more frequently because what we'll get is when we work in the hospital-based system, sometimes what we'll see is patients will come in with a hyperglycemic kind of episode. They'll be within the hospital and they'll be like, they can't even have the sheets touch their feet. It's kind of this burning electrical shock feeling, clothes are irritating them, and they really have poor glycemic control. Those are one of those first acute findings I'm looking for that small fiber neuropathy. And I usually test them at that point for kind of the hot cold distribution, as well as the pinprick kind of sensation at that point in the hospital. And what we're trying to do here at this acute sensory is really get that glucose under control, really start working with their primary care physician on really getting good glycemic control, working on weight loss, working on any of the kind of other issues that come with this acute sensory neuropathy. Now, if the patient doesn't do that, they end up with this chronic sensory motor neuropathy. In this picture, and we all probably seen it before, the stocking and glove distribution. If it becomes more long-term, sometimes they'll even have that kind of central abdominal kind of changes as well. This is the most common I see in practice, and it's true. They have the document of 3/4 of all diabetic neuropathy. This is the one I see the most commonly, and you probably do as well. These are the people that kind of let it go on for a long period of time, feeling that stocking and glove. If we get really, long into their diabetes, what we see is that essentially the length kind of tends to increase. So instead of just their fingertips, now it's their hands, or same thing on their feet. If it's been there for a while, it's no longer their toes. It's essentially their whole leg or whole foot and lower leg. And this again is more symptomatology management this time, and then sending over for treatment with Dr. Leo, to be brutally honest with you. And then the last one from kind of the neuropathic standpoint is the autonomic neuropathy. And from a foot and ankle perspective, what I typically see at this point, I'll see some of those digital contractures. So I'll see some hammer toe deformities, as well as that really xerotic or that really dry type skin. And from the primary care world, you guys are seeing more of the, gastroparesis, the cardiovascular issues, the peripheral arterial disease. We're seeing a lot of that. I typically, when I do my first evaluation of a diabetic that comes in, and they usually come to me at these later stages, and we'll see a gastric stimulator and kind of had multiple stents for peripheral arterial disease, and it just gives me a better idea of really where they're at in their disease process. Now, one that I think maybe Dr. Rumley could speak to, or that I see not as often, is some of this mononeuropathy. Now, the mononeuropathy, when I do a basic patient overview, sometimes I'll see some of these cranial ones. So sometimes I'll see the oculomotor, or that third nerve palsy, when their eyes are one eye's a little bit more kind of droopy or kind of off to the side, or I'll even see kind of the seventh with the facial being a Bell's palsy. But I don't typically in my own practice see truncal or kind of those multiple mononeuropathies. I don't know, Dr. Rumley, are you still on?
Yeah, I'm here. Yeah, I mean, I see them, but it's usually pretty advanced disease or something else. It's usually a diagnosis of exclusion for me.
Yeah. And so those are some of the things from the mononeuropathy that I just don't get a lot of exposure to, but I imagine it would probably be on your end on the longer term, or the more further disease process, to be brutally honest with you. Now, I tried to wrap this all up into one slide, and this kind of came out. I've had to find a good book to really get this, but this is another one of those take-home slides, because it really gives you essentially all the information you could possibly need about all the different kind of diabetic neuropathies, and really what we're trying to think on basic things, what we're doing. And I included entrapment because this chapter from Vinnick was in there, and I thought it was kind of the perfect catch-all slide for everything we just talked about. But it gives you kind of the mononeuropathies, more of the cranial nerves that involve the entrapment neuropathies, kind of making sure we rest them, splint them if we really need to go in and release those. And then for the actual kind of small fiber, large fiber neuropathies, how gradual they are, kind of the distal symmetrical picture that it is, and then kind of the nerves that are involved being both mixed motor, sensory, and autonomic, and then really what we do there. And so from my end, I tried to blow through this because I really wanted to give Dr. Leo as much time as I possibly could, because I think just the things that he's doing is so kind of groundbreaking. I'll turn it over to him.
Okay, well, thank you very much, Eric. That's a great kind of compilation of what we're up to and what we're up against. And I think that it's worth noting, as probably most of the folks in our audience know, that probably half the people who have diabetes have some form of diabetic neuropathy. And we're probably talking at this point tens of millions of people in the United States. So this is a significant portion of the population. And so it's something that we're going to see a lot. And unfortunately, as the incidence of diabetes increases, we're going to see more of it. So after understanding a little bit of where we're coming from, it's where to go. So a little history to why this is relevant right now is when I was at the Colorado Pain Society meeting last October, I had the opportunity to meet with one of the nerve stimulator companies that had just gotten the FDA approval to use spinal cord stimulation for diabetic neuropathy. Okay, I think I just got bigger. And I was really excited with that because this is a modality that I was already using, and it has a new application that we can then apply for. And I was in an office with a podiatrist who I was already working with,
Right here.
and it was kind of a good fit for that. So that got me pretty excited for that. And some of the results that they were getting, we actually had the first year results shared with us at that point, and those had not been published for about a week until about a week after that, showing some of really incredible recovery that these patients were having. So if we look at the slide right now, this is kind of actually an overview of where we're headed here, is that there are multiple treatments and places that we can go to make this better. Pharmacological therapies, some topicals that we're going to talk about, combination of all of the above, and more of the physiologic, and then the stimulation that we're going to go to. There is a large X through the opioids over there because those are a pariah right now, but I will say that there are a couple of things we want to look at in there as well. So just a quick review of pharmacologic therapy. I'm not going to touch on everything there is, but we'll start with the antineuropathic medications. Most familiar are going to be gabapentin and pregabalin, so Neurontin or Lyrica by brand name. And those have now been around for quite a while, are actually remarkably similar molecules, but react differently to different people. So if someone fails one, they may not necessarily fail the other. Reason these are important is that the FDA indication involves failing one or the other of these medications, and one or another of antidepressants, such as the tricyclic antidepressants, which have really been added to pain medicine for a long time now, because they have, at low doses, some good pain relieving qualities. At high doses, the side effects really make them undesirable, both for antidepressant and for treatment of pain. And also the SNRIs, so the selective norepinephrine, or I'm sorry, serotonin and norepinephrine reuptake inhibitors. And it's the norepinephrine part of that pathway that matters here. The serotonin, the SSRIs really don't help a lot with pain, but where we see the norepinephrine descending pathway working in our favor is where those help for us. Non-steroidal anti-inflammatories, acetaminophen if the patient doesn't have liver disease, mixed COX-1 and COX-2 inhibitors. COX-2 specifically would be things like Celebrex, and that's really the only one left of those. There are some that are more that way than others. So depending on which one your patient can tolerate, and also with diabetic patients, we have to be mindful of their renal status and any renal disease before using those. We also have what are considered novel agents, tapentadol, which covers the mu receptor and that descending pathway with norepinephrine, tramadol or Ultram, which has become a mainstay now, and ketamine in a variety of forms, either topically or IV or ingested, or actually as a nasal spray, depending on how you want to apply that. Helps a lot with some of the neuropathic pains. Topical preparations, you can have a number of compounding pharmacies put together any number of the medications we just discussed in a topical, and that will help some people. There are some good lidocaine patches available now that actually stick to the skin, which makes them far superior to the older ones and over-the-counter ones. And we'll get to capsaicin in just a second. I'm going to put opioids up here, even though we're not supposed to use them anymore, but actually they do have some uses. And in this case, I would look mostly at buprenorphine, which is available as a patch, a Butrans patch, or now there is a There is a generic of that, and also as a buccal preparation, which is twice a day and absorbed through the buccal mucosa. Actually, Suboxone, which is on label for a treatment of addiction and opiate misuse disorder, is also very good as a pain medication. And those all have to be taken either transdermally or through the oral mucosa, because stomach acid destroys about 90% of that medication. The more standard oxycodone, hydrocodone, hydromorphone, oxymorphone preparations or an extended release may have some benefit, because the patient's pain may not only be from their neuropathy, and small doses of that in a controlled fashion may be helpful. The other thing that I put here at the end are steroids. And the reason I put them at the end is, while we may be looking for an anti-inflammatory, a patient with diabetes usually reacts very poorly for steroids, except in exceptional cases where respiratory or other issues may be there. So it is something they can tolerate, but it's something we really want to consider at the very end, or possibly as a burst. So the capsaicin patch, which is available, there is one preparation right now. It was formerly approved for post-herpetic neuralgia, and that was when I started using it a number of years ago for that. It sort of went away for a little while, and they did some studies for diabetic neuropathy instead, because there had been some other ways of applying capsaicin to the feet for that. But either way you use this, it requires anesthetizing the area before you put it on, because capsaicin is what's in hot chili peppers, and at an 8% concentration, I don't know how many Scovilles that is, but I bet it puts a ghost pepper to shame. So this stuff really burns, and it is painful if you do not prep the patient appropriately. And it's also painful if you do not wash your hands and make sure you had on double gloves and things, because an hour later you can still make your eyes burn. So the capsaicin patch comes, and you basically cut that to fit the patient's foot. You mark that out, the area that they are numb. And then you apply a topical anesthetic gel, either a lidocaine or an EMLA type preparation. And once the foot is anesthetized, then you can place the patch and wrap the patch, and it stays on for 30 minutes. Patients will usually have a burning sensation or discomfort for a few hours to a few days before things begin to work a little better. Mechanism of action is at the TRPV1 receptor when it's working in this case. And part of what it also does as you move forward and do this at every 3 months is it actually starts to make the nerves burn back a little bit. As I said, there is initially a fairly robust burning sensation, and some patients tolerate that better than others. So that is whether they will continue this particular therapy depends on how well you prep them and how well they tolerate it. So fibers are slightly kind of pruned back, if you will, and that is a basis of the capsaicin. And then over the next 2 to 12 weeks, they start to grow back. 12 weeks is about 3 months, and we end up reapplying this every 3 months on that basis. So essentially, you have a patch that once you are ready to put it on, you peel that, put it on the skin, wrap it. Sometimes we actually pack the patient's feet in ice as well, besides prepping them with the local anesthetic. This is a slightly busy slide, but it'll show you on the left side that the capsaicin, you can see where the nerves have grown, have been pruned back. By week 12, they're starting to come back, and that's a good time to treat again before they have fully recovered. And at 24 weeks, they're almost back to normal. So typically what we'll see is in patients who tolerate it well is the 3rd month, they'll come in for a repeat treatment. Briefly to go through some of the studies here, group of 369 patients were randomized 1-to-1 to get a capsaicin topical or a placebo patch for 30 minutes. And the folks who had the capsaicin did better, measured within the first week or two by a statistically significant amount, about 30% in the capsaicin group and about 20% in the placebo group. This is sort of a reiteration of that same slide, showing that this worked well for folks, and it also worked far longer than just the 12 weeks where we're coming back in to reapply for people. Interestingly, the time to get 50% of the patients to get a 30% reduction in their pain was about 20 days, 19 days in the capsaicin group, and about 72 days in the placebo group, which is about how long the study period was. So more patients with the capsaicin got better. That's not really surprising. What is interesting is that a majority of the patients, better than 50%, didn't have a change in any of their other sensations, such as just better sensation, heat, cold, things like that. But a percentage, somewhere between 12 and 30, actually had improvement of that as well. A few people had worsening symptoms there. The second study here was a placebo patch with standard of care treatment versus a 30-minute application and 60-minute application. And what we see is that the 30-minute and 60-minute capsaicin both did better. The thing that was a little surprising is that whether it was on there for 30 minutes or 60 minutes, it was about identical. So it really helped decide that the 30-minute treatment is all you need to do. What we see here as well is that in the patients who had capsaicin, they had either no change in their other medications, antidepressants, opiates, anti-epileptics, or it went down, whereas the folks who were treated just with standard of care actually would go up. At the end of study, folks who had the treatment and who tolerated it would prefer to do it again and continue that kind of treatment. So the takeaways here are topical capsaicin applied this way does help people. They have improvements in sleep, they have improvements in pain, they have more activity when compared to people who did not have that treatment. So now let's move on to what's really the new cutting edge here now. Again, an old treatment, which is spinal cord stimulation, which has been around since the mid-1980s. And that this is now something that is approved for use in patients with diabetic neuropathy. So a systematic review essentially showed that more than 50% of the patients had a 50% reduction in pain, had improvements of quality of life, improvements in their visual analog scale. And where are we going with this is a high frequency stimulation at 10,000 kilohertz, which the body does not perceive. So you turn the system on for people and they don't know that it's on. And in a couple of days, they start feeling better. So I whimsically refer to this as Harry Potter medicine because it just like it's magic, it works. And we'd be just at about a time to get an 18-month update here, but it has not been published that I'm aware of. But so here we can implant a spinal cord stimulator system. These have been proven to be safe and effective for a number of other pain entities. And what we're seeing is that better than 80% of the people had improvement. 62% of the people, and this was not one of the endpoints of the study, but was found as they went, had improvements such as less numbness, less burning, less tingling, improved sensation, significant reduction in pain with a concurrent improvement in sleep. And if you talk with any chronic pain patient, you get them a night of sleep, good night of sleep, they're going to have a better day, and they start having a spiral up. So we've had over 70,000 people treated with spinal cord stimulation. It seems to be safe, it is effective, it is not without its problems, but it works very well for a lot of people. And the two testimonials here are essentially that once the pain changed, their life changed with it, and a better night of sleep, less pain, less fatigue from that, and they do better. So the 12-month study here showed 216 patients in a randomized fashion. They were split into two groups. They had to have failed the gabapentin or pregabalin and at least one of the other classes of medications that we discussed earlier. These were multi-center prospective studies. And at 6 months, there was a crossover allowed for patients who were in the placebo group if they chose to, or if it was felt to be indicated. An interesting thing here is that the hemoglobin A1Cs were 10 or less for an operation. Most surgeons would like it to be 8 or less. They compared this in one of the companies also makes pacemakers, is that they put pacemakers in people with that and they tend to do pretty well. And so in that sense, it's a similar procedure. So what you see here is you place the stimulator with a trial. We'll discuss that in a sec. Within a month, people's pain has gone from an average of around 7 to an average of around 2, and that they stay at that level. And at the 6 month, the patients who were allowed to cross over showed a similar pattern. Within a month, they were down around a 2. 84% of the patients in that study elected to go ahead and switch over, and none of those switched back. This has been safe, and what we're showing is that only 5 of those people had infections, and only 3 of those infections led to an explantation. The others were treated with antibiotics. So that's actually about 1%, which is pretty good. So how's stimulation work? We implant leads into the epidural space. We do a trial first. The electrical signals either interrupt the signal that goes to the brain via the dorsal columns, or at these very high frequencies that we stimulate, we're actually stimulating glial cells that are then modulating the neurons themselves. So indications: post-laminectomy syndrome, lumbar thoracic cervical, chronic regional pain syndrome, formerly RSD, leg pain, radiculopathy. New indication is peripheral diabetic neuropathic pain, and there was just a new indication for non-surgical low back pain. Benefits is that this improves quality of life, it decreases pain, it improves activity, and it's a smaller operation for patients who've had multiple larger operations. This is a good alternative for them, and hopefully, if this works well, it also allows us to decrease their medications. So as we've already discussed, diagnosis of diabetic neuropathy, try to get them treated, standardized, get their blood glucose under control, get their hemoglobin A1Cs. Ideally, we'd like less than 8, but as I said, we could do this at 10. We discussed criteria for this. And then a patient will be sent to me for consultation for trial. We'll discuss this. If they are amenable to going ahead with a spinal cord stimulator, they may just say, hey, doc, I don't want another operation. I don't want something in my back. And so really what's important here is patient selection. If we do a good interview, a good discussion, and good patient selection, we're probably going to have a good outcome. One things that we have to do is get a psychological evaluation to make sure that the patient is not so depressed that this is going to affect their treatment. I just had a patient who had 12 weeks of psychotherapy and then came back and was deemed ready to proceed, and we'll be implanting a stimulator for him shortly. One of the biggest hurdles now, and just about everything we do in medicine, is getting approval. So that's the first thing to do after you decide you want to go ahead. Once we go ahead, we're going to do a trial. The leads are percutaneously placed. These were placed a little lower than normal because they typically cover from T8 to T10. These were further down because we were looking to cover a patient's feet a little better. But the leads are placed percutaneously into the epidural space, the same way you'd put in a labor epidural, except that we're sliding them a little higher up. We look at them at the AP and lateral under fluoroscopy and place them. They're secured to the skin. And this is done in the OR with anesthesia care. And the patients can take that for a week and essentially take a test drive. The representatives from the company are working with them the whole time, adjusting their therapy and seeing how they feel. And this gives them typically 10 to 7 days, depending on when they can get back. And we don't want to go longer than that because we do not want to have an infection, especially in a diabetic patient. So when they come back, we'll remove the stimulator. We'll talk about how they felt. Was it great? Was it not great? How did it go? And really, they fall into about 3 groups. Some people are like, this was the most amazing thing ever. I want to do this yesterday. Other people were, no, it really didn't help, or I hated it, or I didn't like the way it felt. And there's a group in the middle that they're kind of not sure. And for that group, you check back with them in about a week, and then they sort of will go like, wow, that was better than I thought, or you know what, that just didn't float my boat. And then we've got other places to go. So after the trial, if we decide to go ahead, we basically have to go back to the insurance companies, make sure that we have had all the discussions that we have to with the patient. Again, review what's involved in a permanent implantation. I just had to do a peer-to-peer for a patient today who had a tremendous result, but they didn't like 3 lines of the notes, so we had to reiterate that for them. That patient is now ready to be implanted in about 2 weeks. So that's a big part of what's going on, and making sure that all the questions are answered and that they're really prepared and they understand what to expect, that you're not telling someone that, hey, this is what you felt during your trial, it's going to be way better later. I would never tell someone that they're going to expect any more than they felt in their trial. If we get that, that's lucky, but I wouldn't want to sell it that way because I think you're placing yourself in an untenable position. So risks of stimulation are typical surgical risks, including things like infection, pain where you do the implantations. The leads can move, and sometimes you have to revise the system, put the leads back, put them in a different place. And loss of effect, sometimes they have a tailing off of how it works, and that's why they meet with the representatives often, and these can be reprogrammed, and there are things that can be tailored to try to reduce that problem. And the other thing is it didn't meet the patient's expectations, which is why I really want to spend a lot of time with people beforehand to make sure they know what to expect, what's going to happen. And then that way they go into it with their eyes open, and we don't come in with that, well, I thought it was going to do this. And I don't want that to happen. Other complications, bleeding into the epidural space. They can't have any bleeding problems. They can't be on antiplatelet medications or other things that would affect that. We keep them off all of their non-steroidal anti-inflammatories, aspirin, things like that. And if we get to that point, we go ahead with a permanent implantation. Typically, if the trial went well, we'll do another percutaneous implantation of 2 leads. We then cut down to the spine and attach the leads to the fascia next to the spine. And we make a small pocket for the battery, which is quite remarkable now. The batteries are about the size of 3 silver dollars in a stack. And they used to be about the size of a pack of cigarettes. So that's come a long way. And we make a small pocket for the battery or the IPG, and then we tunnel the leads over, connect things up. Everything is done sort of like a Bluetooth now. You don't have to pass any things into the field, which makes a more sterile procedure anyway. Make sure that everything's working, close both of the incisions, and everything is then programmed in the recovery room. The procedure is again with monitored care. It's in the OR, it's under fluoroscopic guidance. And for about 8 to 12 weeks after the implant, patients are asked not to twist, bend, lift, do things that would move those leads before they sort of heal or scar into place. And during that time, as they heal, you're going to have to reprogram, because as they get fibrous tissue in the epidural space around the leads, that changes how your electric field is working. And that's something that can be accommodated as well. So typically after about 3 months, patients are free to do anything they want in terms of movement. And by that time, looking at the studies that we had seen before, after 1 month, they're already having a significant improvement in their pain. So they are already trying to be more active and able to get out and lead a more normal life. So that's kind of the Reader's Digest version. We had to really crank through this. It's really exciting. I will just say that I did a trial on a patient a month ago who had diabetic neuropathic pain up to his nipple line. And when I put the trial in, I told him, I'm really only going to say I can help you from the waist down and help your legs. And within 3 days in the trial, he reported that he was feeling better across his chest as well. And we just got him approved, and we'll be implanting his device next week. And so I'm really looking forward to that. And the results that are coming in for this, there are now 2 spinal cord stimulator companies that have approval for their devices for this. At the time we started this lecture and preparing for it, there was actually only one. So we have options that we can use, and I think that this gives us an opportunity to really offer a dramatic improvement for what may be millions of patients. So I would thank you all for your time and attention. Dr. Kuhlman and I will be available for questions and answers from here on out. And certainly you can contact either of us directly if we can help you out with anything. So thank you very much.
All right, that's very good. I got some questions coming in through here that I think everybody would like to have some answers for. So the first one is, Dr. Leo, is there any, like when the FDA did their approval, was there any time frame that they expect these stimulators to last for? Because I know that when people hear the term spinal cord stimulator, at least I as a spine surgeon tend to quickly start, shivering and shuddering and hating life, because I'm certainly of the generation where we saw a lot of spinal cord stimulators placed in for low back pain, where patients felt better for, I don't know, a couple of weeks, if ever. And they were being placed for, I don't know, good reimbursement. This is obviously very different, but is there any kind of, data saying how long these are supposed to last and how long the patients are supposed to get improvement for?
Well, right now, for diabetic neuropathy, as I said, we're actually waiting for 18-month data from the Nevro company, because they're the ones who are doing that study. In general, spinal cord stimulators, the rechargeable devices have about a 9-year limit, and then you have to replace the battery in the IPG. The leads can last significantly longer. So that's sort of the time frame that it'll go. I think that what we've learned over the last few years is that you have to have some variability in the frequencies and waveforms that you program, so that you do not bore the spinal cord in the brain. And I think that's where we saw a lot of the failures. And that's really been research over the last 5 to 8 years that have shown a lot of that. I think that the people who got relief for 2 to 3 weeks goes back to my statement about patient selection. You have to really be meticulous in how you choose a patient, make sure this is something that's going to work for them, and you can avoid that kind of a problem. And it takes constant reprogramming and, sort of watering the plant. You can't just let them go and say, okay, see you later. So I think we're getting better at that. Certainly the technology, the leads last longer. And I think we've come a long way since 1986, when it was a single electrode with a dry cell size battery per 15 to 64 electrodes on 4 leads.
Yeah, I've certainly seen a lot of patients that I believe that their spinal cord stimulators in the mid 2000s were placed in for reimbursement, and that was really their only indication, was somebody got paid well to put them in. And I found a lot of those I've pulled over the years, where they come in, they're like, oh, I didn't know I could have it taken out, when their battery starts to fail and get hot.
Mm-hmm.
So second question is, someone asked, they've had some patients coming in that there's these advertised neuropathy clinics and neuropathy cures. I mean, I've certainly seen these ads, and most of them appear to be very interesting marketing of a lot of times snake oil. Are you guys aware of these clinics, and what do you think or what would you recommend providers tell their patients when they come in with these flyers saying natural neuropathy cures and things like that?
Well, I mean, I would say caveat emptor, let the buyer beware. I can't vouch for those. I would say you need to make sure at least that whatever treatment they're putting forth is FDA approved. When you get a disclaimer like this is not meant to treat any disease or entity, there's probably a reason they're making that disclaimer. I think that some of the things we didn't touch on were like making sure that the patients have good nutrition, that they've got the B vitamins and that they've got the omegas and all the things that are shown to be helpful for nerve maintenance and nerve growth. I'm maybe not watching the same late night TV that you are, so I haven't seen them.
I thought it was in 5280. There was an ad.
Yeah, I've seen a ton of them, and I get unfortunately all the patients that come in after there to say what's next, and so that's always my issue, right? If they go in there, spend thousands of dollars to get this snake oil, and then they come in back to you and say, well, that didn't work. I just spent all this money. What do I do next? Yeah. And that's always the hardest question to answer, right? Because they just wasted a ton of money. And now you're going to say, hey, we're going to try something a little bit more basic. And they're expecting a end all be all. That's an issue for me. And I always warn them, because I get a ton of those patients that come in with these pamphlets and say they're recommending, even all these weird injections, all these weird things around my nerves, and we're going to do it. And I'm like, listen, be really careful with this, because there is not a lot of New England Journal of Medicine articles that will back this up. And I always kind of clarify with them that say, hey, there are people out there that do studies, but differentiating a good study by a bad study is always what we're looking for. So I always tell them I look for level 1 evidence, a blinded, randomized study that shows me this is a good treatment for neuropathy. And none of those clinics can support that. And so if you need an answer to say, hey, I need to tell my patients something, you're like, listen, they just don't have any level 1 research, which is, documented as being our highest level research to explain to these patients how it's not going to benefit them.
Right. Now, I know that one of our physical therapists has asked, and I saw this for causalgia, anodyne and light therapy for peripheral neuropathy. I mean, I know in causalgia, at least with occupational therapy, that's something that's been shown to potentially help. Have you guys used that at all? Do you guys well versed in that?
I have been exposed to it, no pun intended. There are increasing basically machines available for that. I think the bottom line is that you're trying to find a wavelength of, quote, cold laser light that induces essentially better vascularization and better blood flow. Yeah. And whether that's just by heating the tissue or whether it's actually inducing growth remains to be seen. Again, they have studies. I think most of the studies tend to be anecdotal as opposed to a good placebo-controlled study. I wouldn't count it out at this point, but it's not something that we use here on a regular basis or at all at this point. It is a good cash cow, though.
It is finding ways to create dermal injury without causing injury to the keratin layers. That's what the goal of the capsaicin is. It's to increase, those healing protoplasms under the skin to try to get the nerves to either rejuvenate or scar down and, become less painful by going away. Because that's also one of the things in the study you showed that actually is helpful is if somebody has diabetic neuropathy and it's painful, well, if they have no pain, that's better than painful neuropathy. So no sensation, although it is not the best, is still better than very painful sensation for a lot of these patients. So,
well, the pain stops them from having a quality of life, being with their family, or really just getting up and not having blood clots. So,
Oh, sorry. Go ahead, Eric.
I don't know. I think about it this way, especially with light therapy, is where the science hasn't caught up yet. So think about protein kinase C, kind of what we talked about earlier. Back in the 2010s, that was the biggest push, is we're going to treat protein kinase C beta, and it's going to change all these atherosclerotic things, and it's going to make everything better in neuropathy. Turns out there's a family of like 12 different protein kinases that we need to actually take into consideration depending on what exactly macrovascular changes there are. So same thing with what we're talking about, so capsaicin, light therapy, getting these microdermal kind of perforations to get change is hard because we don't truthfully have a great grasp on what light, how long, what frequency is really what to use. So I think I agree with Dr. Leo, don't count it out yet, but I don't think we're truthfully there on a model that is successful.
So two quick questions. One, for Suboxone, some people have a hard time getting Suboxone approved because it requires a DAX number. Do you have any recommendations for the audience members? Do you think that it's worth them getting that extra training? And once they have that training, does it make it easier to get approved?
Well, here's a quick myth. One, there are two preparations of buprenorphine that are available on label for pain. And one is a patch, and one is Belbuca, which does not have a generic yet. And that is a little thing that dissolves between the cheek and gum over about 20 minutes twice a day. Both of those are on label for pain. If you can, they're actually C3s. So you can write for them if you write for medications. Suboxone can be written off label, just like methadone can be written off label. I have an X license for Suboxone, but I only need to use the X license if I'm treating someone for addiction. If I'm treating somebody for pain, I write on the prescription Suboxone this much for pain. And really, you're going to see it as the generic, which is the buprenorphine and naloxone preparation. You write it for pain, big block letters, and anyone can write that. And I just had a patient where I wrote her for a Butrans patch. Her copay was $450, and she's on a fixed income. I wrote her for Belbuca. Her copay was $500. And then I wrote her for Suboxone, 2 milligram strip, cut it in half, take one sublingually twice a day. Her copay on that was $7. And she's doing just fine. Thank you very much. There is also a preparation that's available, Subutex, which does not have the naloxone in it. It's not available as a strip right now. They come as little pills that have to dissolve under the tongue. And the problem is if you try to cut those, they turn into powder. So if you can use the strips and you can write it for pain, anyone can write that off label that way. And, feel free to give me a call. We can chat about that more, but you don't have to have an X license if you're writing it for pain. You have to have an X license if you're writing it for addiction, medically assisted treatment, just like you have to have a special license to write methadone if you're using it for medically assisted treatment. I don't have that license. So the only time I prescribe methadone is when I'm prescribing it for pain.
All right, then last question. I've had a couple of people ask, when you're talking about neuropathy, are these treatments also for non-diabetic neuropathy like post-traumatic or causalgia and chemo-induced neuropathy? Are these also useful for those patients?
I don't know if there's an FDA approval for chemo-induced neuropathy. Certainly for things like causalgia, for nerve injury, we can use spinal cord stimulation. We can also use peripheral stimulation. There are a number of peripheral devices that if we can find where that nerve injury is, we can go directly to that site and put a lead and a battery right there.
Awesome. Yep. We've seen that in our clinic. Patients come in that have such long-standing radiculopathy, they're no longer really a surgical candidate from the surgical treatment. So at that point, it then becomes a causalgia treatment for long-standing radiculitis. So that's awesome. All right. Well, I think that's
that is on label, so
yeah.
We can do that.
Yeah. All right. Well, so it's 7:15 and people want to go home and see their families. So I'm gonna wrap it up. You guys did a great job tonight. I learned a lot. I said I was only going to learn from Downs, but I lied. Learn from everybody. All right. So thanks for everybody coming. I appreciate the food and the fun. For the CME credit, which is why a lot of people hang on till the end, and I'm glad you did. First of all, I'd say contact Karen Johnson tomorrow. She's going to send out an email, and you guys can see the information here for the CME credit through yourcesource.org, and the code is on here 844-202203. If you didn't catch that, you will get an email tomorrow. I want to thank everybody again for watching. We appreciate you guys joining the chat and look forward to hearing about your feedback. Please let us know anything we can do to improve these. We want to make these a really useful event for everybody. This is not just for us. This is for all the providers who send us patients and have questions that we can try to make the medical community stronger and more educated. I also want to thank our co-sponsor, Health Images. They sponsor the CME credit for these lectures. They're doing it this year, and they did it last year as well. And that is a huge, huge valuable gift for us. They've been great partners to work with, and they've done nothing but support us. We really appreciate that. As far as the rest of 2022 goes, we plan to offer 4 more of these CME lectures. Dr. Mike Jansen's our founder and world-renowned spine surgeon, and he'll be presenting on lumbar disc replacements May 18th. So that should be a fun lecture. I have a feeling I'm probably going to be doing this again for that one, just a guess. And we'll have our fellow actually on the chat line to ask any questions. Please try to stress her out. Ask the hardest question she can think of. You should receive an electronic invitation soon for that event, so please sign up in advance. These events actually fill up very quickly, and we've had to turn people away just because they've been very popular. So sign up early. I'd also like to especially thank Jenna and Caitlin. I don't say their last names. Caitlin's is easy because it's black. Jenna's last name looks like gorgeous, but it's like Gouge. I can't say it, so she gets embarrassed. They're our Health Images sponsors. They work with us directly and help us set this all up. So everybody, thank you. And hopefully you have a great night. We'll see you May 18th.